We're delighted that Dr. Farooq is joining us again. A few months ago, we had a very interesting conversation, I believe primarily on cataracts. And at that time, he mentioned that he had prepared other material, and we said, well, good. So here we are. Dr. Farooq is an associate professor of ophthalmology and visual science at the U of C. And he provides comprehensive care for a wide range of eye conditions and performs cataract surgery and corneal, I can't say the words here, transplantation surgery. So all of those big medical words, but one of the good things we liked about his presentation was he broke down some of that language so we lay folks could understand them. So Dr. Farooq, welcome. We're delighted to have you back, and you now have the Zoom floor.
Thank you very much for having me. And I think last time we had a lively discussion, and hopefully today will be similar. So I don't remember if we got through all of the slides from my first from the talk last time. I have that, and I think maybe we were going to talk about macular degeneration, which I hadn't gotten to. I don't exactly remember, but I'm going to start off with that, and that's going to be the sort of the end part of part one, and then I'll go into part two. So so I'm going to share my screen here in a moment. Let's see here. Yeah. All right, so I'm gonna forward through. These are some of the things that I talked about last time. We talked about cataract, we talked about glaucoma, and I believe we covered diabetic retinopathy. So I'll start off with macular degeneration, because I think that was something that you all wanted to hear about a little more. So when we talk about the aging eye, macular degeneration is one of those topics that a lot of us are familiar with, either because we have family members who have had it, or some of you may have been told that you have some findings of it by your ophthalmologist. I think most of us know at least one person who has or has had macular degeneration. So this is also known as age-related macular degeneration. The abbreviations AMD or ARMD are often used. AMD is the most common. So what the ophthalmologist sees when we examine the eye and it has macular degeneration is these yellowish deposits. And the photograph on this slide shows a round circular type object toward the left side. That is actually the optic nerve. And there are all these red lines that are kind of seem to be converging onto that circle. Those are the blood vessels. Those are arteries and veins. So the arteries are coming out from the nerve toward the retina, and the veins are going back. They're bringing blood back toward the heart. And just to the right of the optic nerve is an area called the macula. And the macula is the part of the eye, or the part of the retina, that is responsible for our central vision. So, if you look straight ahead, you'll notice, and you've noticed your whole life, that what you see in the middle is more clear than what's all the way out here for the sides. And the reason for that is because the macula, which is in the center of the retina, that provides the sharpest vision. So even though we have vision out in this area, it's not as sharp. When something affects the macula, that affects the clarity of vision. And sometimes things are just not as clear. Sometimes things can also be a little bit distorted, where lines don't look straight, for example. They might look wavy, or they have a bend in them. A patient with macular degeneration, because of the presence of these deposits, and you can see these yellowish areas, near the macula and around the macula, those deposits can cause some distortion. So a patient with macular degeneration might look at the edge, a door frame, for example, or the side, the edge of a door, and it might not look straight. It might look like it has a curve in it. And they might look at that and say, that door is straight. It's always been straight. And I think my eyes are doing something here. Patients with macular degeneration can often get around just fine, but when doing fine visual tasks such as reading or knitting, or doing those things that require that fine central vision, those things become more difficult. There are two main types of macular degeneration. One is dry and the other is wet. So in dry macular degeneration, you have drusen, which we talked about, these yellowish deposits that are actually under the retina, way inside the back of the eye. And there's also something which we call retinal atrophy. So what is atrophy? Atrophy is where it just gets weaker. Like if your muscles atrophy, the muscles are just, smaller and weaker. So the retina gets weaker. That's dry macular degeneration, or dry AMD. Wet macular degeneration can have those same features as dry AMD, but there's also some fluid. Basically, there's some bleeding that causes some blood to accumulate either under the retina or in the retina. AMD is the most common cause of blindness in the Western Hemisphere. So this is a very important condition, not only to know about, but also for ophthalmologists and scientists to really try to solve. About 2 million people in the United States are affected, and probably the numbers are higher. We just don't have the data. So again, differentiating between dry versus wet AMD. Dry AMD, there's those drusen, those yellowish deposits, there's atrophy, and there's what we call pigmentary changes. When the ophthalmologist looks in your eye, they'll see some color changes, and they'll see the yellowish dots, and they say, oh, I think you have some macular degeneration going on. In wet AMD, there's fluid, there's hemorrhage. So wet meaning fluid, and that can either be detected by looking, or your ophthalmologist might get a specialized retinal scan that actually shows the fluid. So again, the diagnosis of macular degeneration is by getting a dilated eye exam. And it's a good idea to have a dilated eye exam once a year. So the drusen will be seen, the atrophy will be seen, and if it's wet AMD, then there will be fluid or hemorrhage. And a retinal scan which is called an optical coherence tomography. We just call it OCT. So that the full name is a mouthful, but OCT is that specialized scan of the retina, and it provides a cross-section image of the retina and actually shows, is it swollen? Is there fluid in there? Is this wet AMD? So unfortunately, at the present time, there's no real treatment for dry AMD. Now, there are some people working on treatments and investigating them. One of my colleagues, who is a retina specialist, her name is Dimitra Skandra. She is actually looking at some candidate medications that seem like they are having an effect in her experiments on dry AMD. But at the moment, well, I should say actually very recently, there's one drug that was approved for dry AMD. I actually need to update this slide. Very, very recently, there's a drug that was approved. But when I've talked to my retina specialist colleagues, they have said that they haven't been very impressed by the data. So although there is a very, very new treatment for dry AMD, nothing so far is a slam dunk. Now there is a formulation of vitamins. Some of you may have seen this at the drugstore. There are eye vitamins, Ocuvite, AREDS 2 vitamins. There's a lot of different names and different brands of these. These are for patients with dry AMD, but they're only helpful for a specific level or severity of dry AMD. They're for patients who have what we call moderate dry AMD, because there was a study basically showing that some of the patients who had moderate severity of dry AMD, it prevented them from going into severe. But if you don't have AMD, there's no data showing that it'll prevent you from developing it. And even if you have mild AMD, the data doesn't really support using it to prevent it from getting worse. It's really for the moderate severity. For wet AMD, there is a treatment. So that's the good news. Even though wet AMD you might consider to be in some ways more severe because there is bleeding, there are actually injections that can be delivered to the eye that can take away some of that fluid. And those injections are broadly known as anti-VEGF, VEGF, and that's another acronym, vascular endothelial growth factor, VEGF. VEGF causes blood vessels to grow. So anti-VEGF causes those blood vessels to go away, or at least to stop leaking. So dry AMD, there's one treatment out there. The data are limited, not very promising. There are eye vitamins that your ophthalmologist might recommend. And then wet AMD, there are treatments which are called anti-VEGF drugs. One other thing to mention about macular degeneration, if your ophthalmologist says that you have macular degeneration, they might give you like a grid to put up on your fridge. And that's called an Amsler grid. It's basically like a bunch of lines going up and down and side to side. And what they'll ask you to do is to take a few moments every day, cover one eye, and look at that grid. And if you notice that all the lines are straight, then no problem. But if you notice all of a sudden that the lines were straight yesterday, but today the lines look wavy, then you should call your ophthalmologist and be seen, because that might indicate a change in your AMD. Any questions about macular degeneration? Oh, I think somebody might be on mute that wants to ask a question.
Well, I just know, I mean, I have the dry and I'm taking the vitamins. My husband has the wet and he gets the injections. And he says that while they sound terrible, they're not, and the idea of them is not great. Fortunately, they seem to work. He was just in about a week ago, and the doctor was so excited and says it's working. You don't need one today. So I just want to encourage people they think there is a problem, see your eye doctor, because there are some things that they can do to help us.
Yeah, absolutely. And the injections are, you want to make sure that, your ophthalmologist can numb the eye very well. So it should be, relatively, you shouldn't really feel pain. And if you've had an injection once and you felt pain, then you should speak up for the next time and say, can you just really make sure the eye is numb? Because if the eye is numb, it should be a straightforward procedure to have that done.
Yeah, he says it's not painful. It's just kind of boring because you have to lie there and wait for the numbing medicine to take effect. And then it's okay.
Yeah. Is there a hand raised?
Yes, I have a hand up. I was wondering, is macular degeneration inevitable for all of us, although it may occur at different ages, or do you not necessarily get it?
That's a great question. So, you probably, all of us will develop some drusen, some of those yellowish deposits in our retina at some point in life. But we don't call it macular degeneration until and unless there's a cluster of those drusen in the macula. So not everyone develops those, and the reasons behind them are likely partly hereditary and partly, what we call environmental. So lifestyle, diet, things that are, maybe somewhat can be modified.
I have a good friend who just is being treated for this now, and I was curious as to whether or not that means that it can be the progress is stopped, or does it actually improve as you're going through these treatments?
Yeah, well, for the wet AMD, the treatments that are given, the anti-VEGF injections, they're very good and they're very helpful. And before these were discovered, there really wasn't anything that could be done. So it's really transformed the, treatment of wet AMD. However, it doesn't treat the underlying cause or causes. It's more of a reactive treatment. You have bleeding, swelling in the retina, there's fluid. Let's get the fluid to go away. But why is there fluid developing? Can we stop that, or can we improve it? I think that's what your question is getting at. And again, we don't really have great solutions for it. I'll quote my retina colleague again, Dr. Skandra, who really has become an innovator in this field, because she has seen in her experiments that it seems likely that eating a very healthy diet, what's called the Mediterranean diet, that probably has some protective effect against macular degeneration. And it may be because eating a lot of healthy fruits and vegetables, has a lot of these, what we call antioxidants, things that prevent damage over time. But the other thing that she has seen is that eating a very healthy diet might cause what are the good bacteria in our gut to help the rest of our body. And this is a growing area of research, which I think many of you may be familiar with, called the microbiome. So all of our bodies, both on our skin and inside our inside our mouth and inside our entire digestive tract, there are millions of bacterial organisms that live on and in us. And the University of Chicago actually has a very large microbiome research center. And Dr. Skandra has done some research on the microbiome. And based on her research, it seems that the microbiome, the bacteria, good versus bad, may be playing a role in macular degeneration. So I think there's more information to come about how to prevent macular degeneration. But until then, I think eating a healthy diet, and there's a specific, the quote unquote Mediterranean diet is actually a very specific diet. And I would suggest consulting with your doctor before making any big dietary changes. But eating a healthy diet, getting exercise, I think those are likely to be beneficial in preventing macular degeneration.
I don't want to change the topic. Because I have a question that somebody's asked, and I'll present that, but it might change the topic right now. Is there anybody else that has questions about macular degeneration?
Well, I do. Can you
Go
hear
ahead.
me? Yeah.
Go ahead.
Is it something in an early lifestyle, or when you grew up? Do they know what causes it in certain people and not in others?
Yeah, exactly. I think we're sort of at the brink of discovering these things in the field. Part of it may be hereditary, if your parents had it and their parents had it, you're more likely to have it. But I think there are lifestyle, diet, exercise, modifications that likely impact when you're going to develop it, or if it can be delayed, or if you're going to develop it at all. Most people who develop macular degeneration, the signs of it don't show up until 60s or 70s or 80s. And we don't really see much until patients are above 60 years of age. Again, I think that the data that's coming out, the research that's coming out, is supportive of the idea that there are a lot of things that we can probably modify in our behavior, in our diet, in our exercise patterns that likely have a benefit. And I think that the coming years will show exactly how to do that. But eating a healthy diet, such as the Mediterranean diet, getting exercise, those may be ways to kind of put off the onset. Things that are good for your heart are likely also good for your eyes.
Okay, thank you. By the way, I'm Dr. Skandra's patient.
Ah, yes.
Yeah.
Has she talked about some of these things with you?
A little bit, but I didn't know much about the wet and the dry. And so I get the injections every 6 to 8 weeks.
Yes.
Yeah. And she often says, you know, it's improved. That probably means it's not developing. It's not going forward, but see where it goes. I'm an experiment.
Yeah, sure.
Mm-hmm.
Well, I'm a patient of hers as well, and I think she practices what she preaches. She's a tiny person. I don't think she eats a lot of donuts, let's say.
I think you're right about that.
Yes.
I think you're right about that. All right, so I see a picture, not a picture. I see a question in the chat about difference between ophthalmologist, optometrist, and optician. So an ophthalmologist is someone who has.
Before you go there, Alice had a question, and her question was, can you find an Amsler grid online to download?
Yes. Yeah, I think there are a couple links that have been shared.
It's already in the chat.
Yeah, in the chat. Yes. Yes, there, you know, an Amsler grid, yes, there are places online that you can download one and you can print it out.
So there's a picture of one that looks for the normal eye, and then what it looks like if you have macular degeneration.
Yeah.
Just do an image search.
And then Sarah has a question. I want something like that for glaucoma. So can you ask your question, Sarah?
Oh, I just wondered if you'd already covered glaucoma.
Okay. I didn't cover it today. If we have time, I'm happy to. I do have some slides on glaucoma in this talk. I believe I'd covered it last time, but I'm happy to go back to it and kind of go through it briefly so that you have, you know, so that we can discuss it.
And if he doesn't get to it now, his previous presentation and slides were uploaded on the Hyde Park Village YouTube. So you can go back and see that whole presentation again, or for the first time.
Great. Thank you.
So I have a question. We talk about all these things separately, but like, well, I turned 80, so they are watching me for cataracts. So, you know, and they say I have the beginnings of dry macular degeneration. So we've got that. Then because I took Elmeron for bladder issues, now I see Sandra for the retina, that there's an issue. Is that common that people have multiple eye issues?
Yeah, that's a great point, and I think that you know, there are in the you know, in the aging eye, you know, there are so many different components to the eye. You know, I often use the analogy of a camera. You know, the eye has a lens. The eye has, well, at least the old-fashioned cameras had film. So the lens is like the cataract. It's just a lens that's no longer clear. That's what we call a cataract. And then the retina is like the film in the camera. That's what processes the light coming in and captures that image and sends that image to the brain. So cataract, macular degeneration, glaucoma, dry eye, these are all very common, and these can often occur at the same time. And so it can be surprising and also a little bit overwhelming to all of a sudden be in the position that, okay, I have to see a cataract specialist, I have to see a retina specialist, I have to see a glaucoma specialist. All of a sudden, you wake up one day and you have 3 different ophthalmologists who are specialized in that narrow field. You know,
And so with that, we welcome you. We're delighted to have you here to share.
yeah, so again, I think your point is a good one, that these things often can happen at the same time, and it's not unusual to be visiting a ophthalmology clinic to see different folks, because we often have different areas of expertise or knowledge. I speak on macular degeneration as a ophthalmologist who knows about it, but the retina specialist who's they're the experts. You know, they treat it, they do the injections and, you know, monitor it. And so the eye just has so many components, and it's so complex that that's how we approach these issues.
Lucas just posted on the chat box the link to the previous presentation, which interestingly enough was a year ago. What
Okay.
comes around goes around.
Perfect.
Yeah, also upon just quickly scanning last year, it looks like we focused, yeah, largely on cataracts and did touch on macular degeneration, but I don't think we had a chance last time to delve into glaucoma. I don't know if Dr. Farooq, if you have any time to delve into that a little bit this time.
Yeah, sure. I'm open to cover whatever you know, the group wants to cover. I think glaucoma is certainly an important topic, and I have a section here. So let me share my screen. Were there any other questions before we delve into glaucoma? Okay, so let me go here, share my screen again. All right. So first we'll talk about, you know, what is glaucoma? So glaucoma is a condition in which the optic nerve gets damaged over time. The optic nerve is the nerve that connects the eye to the brain. It's way in the back of the eye. If you recall the picture of the retina that we were looking at with macular degeneration, there's a round object. That was the optic nerve. So the optic nerve is where all the signals from the retina, the picture that's kind of created by all the light signals coming in, they all converge and come into the optic nerve, and then they travel, that signal travels to the brain. So we call it a progressive optic neuropathy because because the optic nerve, neuropathy is like a nerve problem. You know, you have neuropathy in if you have neuropathy in your hands and feet, you can get tingling or loss of sensation or pain. Basically, it's where nerves are not working like they should. That's neuropathy. And it's progressive because it gets worse over time. Usually it's a very slow process. It takes many, many years. So that's why we say glaucoma is a progressive optic neuropathy. And it leads to loss of vision. But one of the things about glaucoma is that you start off by losing vision way out in the periphery of your field of vision. So that's why patients might have glaucoma for a long time and they don't know it because their central vision is pretty good. They can still drive, they can still read. But if it progresses long enough, it can actually affect the central vision as well. And that's where glaucoma gets scary because we don't have, up until now, we don't really have the ability to reverse that damage. Most people, once you lose parts of your field of vision, you don't really get it back. Now, in most cases, glaucoma is associated with elevated eye pressure. We call that intraocular pressure, or IOP. Now, this is not thought to be related to blood pressure. Patients can have high blood pressure, but good eye pressure. This is specifically about eye pressure. And if the eye pressure is up, it's not good for the nerve, generally speaking. A lot of patients have glaucoma, more than 3 million people. African Americans are 5 times more likely to have glaucoma and 6 times more likely to become blind from glaucoma. So where does the pressure in your eyes come from? I often talk about the eye as like a beach ball. If you fill up the beach ball completely with air, the beach ball is going to be, very full and kind of, rigid. If you push on it, it'll bounce back. If you only fill the beach ball half full of air, it's going to be very soft and squishy. And what we measure when we measure eye pressure is the resistance to being like indented. So if you push a beach ball, it's full of air, you're not going to be able to push it very much. You're going to have to push a little harder. If the beach ball is only half full of air, you're not going to have to push very hard with your finger. It's going to indent. So what we measure when we measure eye pressure is actually indentation pressure. It's how much force does it take to push the eye a little bit. We numb the eye before we check the pressure so you don't feel pain from it, but that's what we're measuring, how much force is required. And the pressure in the eye is a balance between fluid that's made in the eye to keep it formed and filled, and fluid that leaves the eye through the drainage system. Now, the fluid that leaves the eye is not the same as like your tears. If you have a watery eye, that doesn't mean that your eye is like leaking fluid. That comes from different tissues and glands around the eyeball. The fluid that is developed inside the eye and that leaves the eye, it's all internal. And it leaves the eye, but it goes back into your veins and goes into your heart. It doesn't come outside. And again, it's when the eye pressure is high or the eye pressure is elevated, that's what causes a problem, because the nerve gets damaged from that. Now, when your ophthalmologist looks at your nerve, there's a nerve that looks healthy and there's a nerve that looks like it might have glaucoma. And you can see in this photograph, the healthy nerve is that yellowish round object where all the blood vessels are coming together. And that it's like a pinkish circular object, but it has a yellowish area in the middle. So we talk about a cup to disc ratio. What we mean by that is like when you look at a teacup on a saucer from the top, that teacup should be small compared to the saucer. It shouldn't be the same size, or it shouldn't be big. The cup versus the disc. If the cup to disc ratio is large, so like the nerve on the right, that yellow portion, on the left image, it's very small. And the image on the right, the yellow circle is big. That's a large cup. And so that makes us worried about glaucoma, because that means that the nerve has some damage, or possibly has some damage. Not everybody with a large cup has glaucoma. We have to do more testing to figure that out. But when we see a large cup, we call those eyes or those people glaucoma suspects. So you're a suspect, but you haven't been convicted yet. it just means that you have to go through further testing and monitoring to see, is there any damage to the nerve? Are there any portions of the visual field where you can't see? Because those might be indications of glaucoma. So your ophthalmologist will look at your nerve, they'll dilate your eyes, they'll examine your eyes and see what does a nerve look like. And if it looks healthy and the eye pressure is good, then you're all set. Come back in a year. But if your nerve looks like this, they'll want to do some more testing to check and see, are there any signs of damage to the nerve? And one of the types of tests that are done is this same type of scan that we talked about for the retina, called an OCT. And it actually shows the thickness of the nerve fiber layer. If the nerve fibers are thin, then they might be damaged. You know, we talk about atrophy. Atrophy of the muscle shrinks, it becomes smaller, becomes weaker. Same thing in the retina, same thing in the optic nerve. If the optic nerve is thinning, then that is a potential sign of glaucoma. And then we get visual field testing. So a visual field test is where you go into the office and you sit in front of this device. It's basically like a big bowl that's facing you. And then a bunch of lights go off and you push a button whenever you see the light. And it maps out your field of vision. And in the visual field test, if you don't see the light, so the light was turning on, but you didn't push the button, it could be because you didn't see it. And this visual field, machine basically provides information on, is your visual field normal, or are there parts of the visual field where you're not seeing the light? And that's very helpful to understand the function of a patient with glaucoma. Do they have a very restricted visual field? Is it safe for you to drive or to do other activities? So visual field testing is very important. There are a variety of treatments for glaucoma. All of them are aimed at lowering the eye pressure. That could be eye drops, that could be laser, and that could be surgery. And what is recommended for you will be based on the type of glaucoma that you have, the severity of glaucoma, what the anatomy of your eye looks like, what might be required in your particular case. But laser and eye drops are considered, to be, something that most glaucoma patients may need to utilize. Surgery is usually reserved for those patients who have more advanced glaucoma, although there are what we call minimally invasive glaucoma surgeries that your ophthalmologist might recommend to be done at the same time as your cataract surgery. Because the idea is that if your surgeon is working inside the eye to remove the cataract anyway, they could also help your glaucoma, and that adds probably about 5 minutes to your cataract surgery. So there are a variety of ways, variety of approaches to treating glaucoma. And again, how yours would be treated really is dependent on the severity and type of glaucoma that you have.
Sarah mentioned normal tension glaucoma.
Yes. So there is something called normal tension glaucoma. It's actually not that well understood. So for the rest of you, normal tension glaucoma is what's used to describe glaucoma where whenever you go into the eye doctor, your eye pressure is fine. It's normal. Now, the thinking is that there are two possibilities here as to why patients who have a normal eye pressure whenever they go to the office, yet they still have glaucoma. So one is that the eye pressure is elevated at times that you're not in the office, such as when you're asleep. And there actually is some pretty good data showing that the eye pressure actually is highest while we lie down in the middle of the night. So maybe the eye pressure, normal eye pressure, quote unquote, is between about 10 to 21. So maybe when you go to the office, your pressure is 15, but maybe in the middle of the night, your pressure is 24. But we can't detect it because we're not going to your house and measuring your eye pressure while you're lying down. So normal tension glaucoma could be related to that. There's also some thinking that normal tension glaucoma, the eye pressure is actually normal, but there's some other process going on, such as problems with blood flow to the nerve that cause slow damage to the nerve over time. The thought process, though, is still that if you lower the eye pressure further, that will likely prevent further damage. So even for normal tension glaucoma, the treatment is still lowering eye pressure. I think that there's likely a lot of patients who have a diagnosis of quote unquote normal tension glaucoma who might be having pressure elevations in the middle of the night. We just can't detect it, or we haven't detected it yet. But that's a really good question.
So this might be the last question. Difference between ophthalmologist, optometrist, and optician, and when should I consider going to an ophthalmologist versus an optometrist?
Yeah, that's a great question. So in terms of training, an ophthalmologist is someone who has gone to medical school, so they're a medical doctor. Then they go through ophthalmology residency, which is so medical school after college. So college typically 4 years, medical school is another 4 years, and an ophthalmology residency is another 4 years. And then if your ophthalmologist is specialized in a certain area, that's an additional 1 to 2 years. So I'm a cornea specialist, for example, that was an additional year. So that's 5 years of training after medical school. That's ophthalmologist. Optometrists are folks who have gone to optometry school. That's also generally after college. So they go to college 4 years, they go to optometry school for 4 years. After optometry school, they can actually practice. Some optometrists also do a 1 year, they also call it a residency. It's a 1 year specialized training in certain fields, such as contact lenses, specialty contact lenses, and things like this. An optician is someone who specializes in fitting eyeglasses. So that's the person you see if you take your eyeglass prescription to an optical shop, you want to get fitted for eyeglasses. They're not the people who do the measurement for what your prescription should be, but just actually physically fitting your face with the frames and the lenses and getting the lenses centered correctly and stuff like that. When should you see an ophthalmologist versus an optician versus an optometrist? We talked about when you should see an optician. I think it really depends. So if you have a good optometrist and your eyes are generally pretty healthy, you don't have, cataracts that need surgery, you don't have macular degeneration that's more than just very mild macular degeneration. If you have glaucoma, that doesn't require laser or surgery, and your optometrist is comfortable managing those and has experience with those, I think it's fine to see an optometrist on a regular basis. if you need some more specialized care, if you have cataracts and you think you might need to have them removed because your vision is going down or you're having trouble driving or reading or doing other things, or if you have macular degeneration and it's more than just very mild macular degeneration, and maybe there's some signs of wet AMD, or there's glaucoma and it's more than mild glaucoma, you may need laser surgery for it. I think it's a good idea to see an ophthalmologist, and your ophthalmologist can also provide you with some feedback as far as, should I see you back again, or can I see my optometrist for routine checkups going forward and only see if I have a problem. There's a considerable degree of overlap between what ophthalmologists and optometrists do. I think if you are concerned that you might need something done, such as a procedure, surgery, or if you want an opinion about whether you might need that in the near future, see an ophthalmologist. If you're doing well, if you can see fine, if you don't have any signs of these issues in your eyes, and your optometrist examines you and they determine that your eyes are healthy, keep seeing your optometrist and and ask them, when you might need to see an ophthalmologist to get interventions that you might need. And then if you need your glasses updated, your ophthalmologist or your optometrist could do the measurement for you as far as prescription, but you get fitted by your optician. So I hope that makes sense. Again, I know there's a lot of overlap between ophthalmology and optometry, but in our department, we actually work together, the ophthalmologist and optometrist, we work in the same department. And so there's a lot of overlap, but we also work together to complement each other's skill sets.
Dr. Farooq, can you turn us onto the full screen? And then Audrain will chat with us. You're muted, Anne.
Thank you so much. It was a wonderful presentation. I learned a lot. I hope everybody else did. You put it in terms that is very readily accessible to us. And the same as we all have eyes, it's important that we know about our care for them. No, it's very good. I appreciate it. I appreciate all the wonderful questions too. I mean, people were really following and thinking. So thank you all for coming. Those of you who want to stay on with Laura and chat a bit, just stay on. I think that really concludes it. Terry, do you have any?
Dr. Farooq, 3 times a charm, so we might have you back again next year.
Who knows?
Yeah, I'd be happy to. I have some more things that I can cover.
Oh, good.
Regarding the cornea. So thanks so much for having me. I hope
thank you. Really appreciate it.
Yes.
Very good.
Thank you.
My pleasure. My pleasure. Hope you all enjoy the rest of your day.
Thank you.
You too.
You too.